Assalamu alaikum and good morning, everyone. We'll start off the day with a few basic concepts. In fact, this one is not originally my lecture. One of our colleagues at the Royal Liverpool course, one of the chief's sisters, presented this. This is basically preparation of ERCP patients for a day case. Because traditionally, most of my lists have been in the afternoon, so I admit my patient after the afternoon list because there's not enough time to discharge them. But even now I've converted my list to the morning list because you can do them as day cases, especially with pressure on beds. It's advantageous to do ERCP as a day case. And if you allow them 4 to 6 hours in hospital post-procedure, then it is quite safe to discharge them home if they are well at the end. So usually, if you have to do them as day cases, it's always a good idea to assess them beforehand. We call that as POAC, Preoperative Assessment Clinic. So it's usually run by the nurses, specialist nurses, who assess the patient basically for any risk factors. If they are on anticoagulants, they are on any medication that would interfere with the procedure, or antiplatelet agents like aspirin, clopidogrel. So they are usually assessed, their bloods are checked. So, basic investigations like ECGs are carried out. It is important to find out if they've got anyone to take them home, because if you give them sedation, they can't drive back home. So they need to have an escort with them, and they need to have somebody who can stay at home with them. And we tell them not to sign any legal documents for 24 hours, because if they are under effect of sedation, they can potentially. Yes, yeah. Well, she'll make them sign everything. So basic blood test, nothing special. Any medication they are on. At the Royal Liverpool, they used to give them oral antibiotic prophylaxis before the procedure. I tend to give intravenous in my unit. They are given consent form, they are given full explanation of the procedure, any side effects, any risk factors are discussed. Now, basically, we'll talk about consent. It is part of our assessment as well in the DOPS form, and there is a structure to consent, which I think it would be a good idea for you. Legally, the legal aspect of consent may be different in this country, but the general basic framework is the same everywhere. So what are the key components of informed consent? I'll go through that. Patients should have sufficient information to understand the procedure, its benefits, and the harm that may arise from it, right? So informed consent is that the patient is able to understand, retain, use or weigh up the information given to him and make a decision on the basis of that, and also should be in a position to communicate his or her wishes. Patient is then competent to, if he's competent to take that particular decision, then according to British law, he has got mental capacity. So consent can only be given by somebody who's got mental capacity. We normally presume that the patient has mental capacity unless proven otherwise. It is most important that when you are consenting a patient, he's not under any pressure, duress, or forced into a decision. If he refuses at any time, then there's nothing you can do. So they have the right to choose alternative treatment, refuse treatment, or withdraw their consent at any time. So if they've signed a paper, it doesn't mean that they have to undergo the procedure. They can still come out of it. So if you are going to, it is good practice not to consent them in the endoscopy or the operation theater. They should always be consented outside, because if they are consented in the endoscopy unit, they are under some sort of a pressure or duress.
For our practice, I think because a lot of us don't have separate rooms and all in endoscopy, when you see the patient in the clinic, that is the best time you decided this patient needs to explain the whole thing, and you take a verbal consent at the same time. So as you are explaining the procedure because that's the time, it saves you doing it twice. You can do that right away, and then, you know, when they come to the unit in my own practice, that's what happens.
Yes.
They come and then they will be told again and they'll sign the system.
Now, the day cases, the way we have all these referrals, they just, we see them on the day of the procedure.
Right.
We get to explain the procedure, like not obviously in the procedure room.
Right.
We see them explain the procedure, get the consent. So it depends on what type of practice you got. If you see them in the clinic, that's the best time to get it.
Because for most of the standard procedures like OGD, colonoscopy, sigmoidoscopy, we send them postal consents. We send them a big, you know, sort of booklet with information and consent in it. So it depends on how you carry it out. Now, even if you make them sign the consent form and everything, it is still not legally binding consent. In British law, the consent, even if you've not taken a written consent, the consent process starts the moment you see the patient. If you have seen the patient in clinic, assessed him, and explained the procedure to him, and documented that in the patient's notes, that is a valid consent. Even if you've not signed an actual consent form, because the whole consent process has been completed, and if the patient, after that explanation which has been documented, comes to the procedure, that means that he is doing it under, you know, he's consented to the procedure. So, but, you know, for cosmetic reasons, we all make them sign the consent form. So, basically, I usually teach them, the fellows to follow the embrace structure. E is for explanation of the recommended procedure. M is for motive or reasoning behind the medical recommendation. Like, you know, with E, you explain what ERCP is, you know, the procedure, what it involves, the motive why you are doing it, because there is biliary obstruction or, you know, there's suspected stones or a stricture. Benefits, why you want to do it, because you might be able to relieve the benefit, the obstruction, or, you know, get rid of the stones or put a stent in. Risks, what possible risks are involved with the procedure. Alternatives, like, you know, you can have MRCP done, but it is not a therapeutic procedure. You can have a CT scan done, but, you know, there are limitations. So any alternative procedure, you must tell the patient whether they are good or bad, and their limitations, complications, and, you know, to complete the embrace thing, you put effects on it. Effects, basically, you tell them the side effects of the medication that you use, like midazolam, pethidine, whatever you give them. Right. What happens if your patient withdraws consent during procedure? So what do? Competent adult patients are entitled to refuse treatment, even where the treatment would clearly benefit their health, even if you feel that the patient definitely needs that procedure, and if he refuses it, there's nothing you can do. It is their choice. If you look at ethical framework is composed of 4 components. It is, first is beneficence, which is doing patients good. The second pillar of ethical framework is non-maleficence, which is first do no harm, which is the first part of the Hippocratic Oath. The third is autonomy, and the fourth is equality. According to British law, autonomy supersedes everything else. Even if it is beneficence, it is non-maleficence, but if the patient does not want to have it done, then that is his decision. So you have to respect that. Laws might differ in different countries. I think over here it might be beneficence and non-maleficence. So it depends on what law you are following. If the patient withdraws consent, in unsedated patient, you are required to stop the procedure there and then. You can't legally, because if you continue with the procedure, then that can be termed as assault. In a sedated patient, obviously the judgment of the patient is in doubt, so at that time the endoscopist must act in the patient's best interest, and that is during the procedure. If the patient is having pain or discomfort, you are required to pause, attempt to regain cooperation of the patient, like, you know, if he is distended with air, suck the air out. If you are performing a colonoscopy and the patient there are quite a few loops forming in there, try to resolve those loops and make the procedure more comfortable for it. talk to the patient, give them extra sedation if needed, or we use Antonox as the additional painkiller in colonoscopy. So you can give them Antonox inhalation and wait for the effect. So calm down, slow the procedure down, give them extra sedation if needed, reduce all the discomforts that are possible, and then if the patient agrees, you can continue. But if this patient, after all those maneuvers, is still adamant, he doesn't want the procedure, then you must terminate the procedure. Right, so basically the do's and don'ts of consent or assessment, right? So I think I'll just skip through that. Now there was a thing called NC pod, because even in UK the practice of endoscopy was quite unregulated about 10, 12 years ago. So there was a national confidential inquiry into patient outcome and death. The surgeons took a lead on that, and they did that, and they revolutionized the whole practice of surgery there. And this thing was then taken up by the endoscopy practice as well. And that was the aim of the study, was to improve the quality of therapeutic gastrointestinal endoscopy services. And the outcome was that we made sure that there were fewer inappropriate procedures carried out, lower morbidity and mortality as a result of the procedure. There was better training facilities, and the needs for training were identified, and recognition of poor performance. In the past, you could get away with murder and nobody would take. I used to have a vascular surgeon performing endoscopy lists next door to me. I mean, why would a vascular surgeon need to do endoscopies? But it was one of his lists, and he used to do it, and do it badly. Reduced litigation because of, you made the whole process more transparent. If I am performing endoscopies, I've got my whole year of audit data behind me. Every year, my department publishes my performance figures. So anyone can access that due to Freedom of Information Act. So it's nothing hidden about me. You can go online and do it on my hospital site. So like in ERCP, this is gross numbers, not necessarily procedure related. 37% death in the first week post ERCP, because some of these patients have got malignant diseases, some others. So so 88 patients out of 237 patients in the ERCP sample died, 30% in the second week. So then as a result of this, was the first time they looked into the practice of endoscopy. So a lot of issues were identified. And the good thing about those countries is that when they carry out the audit process, they pick up the issues and then they act upon it. And that's how you make improvement in your practice. Because as I said, even in UK, our practice was pretty unregulated, not anymore. And there were some very simple recommendations that were made. Pulse oximetry following procedure, oxygen supplementation, better monitoring, like ECG monitoring, blood pressure monitoring during the procedure. So to sum it up, they said that above all, to provide timely and optimal care in the best interest of what is a significant proportion of sick patients in every hospital. Because when you carry out procedures on patients, especially like ERCP, either they are septic, they may be in septicemic shock, they may have acute pancreatitis, or they may be deeply jaundiced because of an underlying malignancy. So these are inherently sick patients, and if you carry out invasive procedure in an unregulated manner, you would cause more harm. I mean, it's just like performing surgery. You wouldn't dream of performing surgery on an unfit patient. So the same respect should be given to most of your endoscopic procedures. So post-procedure, the recommendations were that following ERCP, a quarter hourly for pulse, blood pressure, respiratory monitoring, plus pulse oximetry, it's done on that basis.
Is that a standard practice in your unit?
Well, sort of. I mean, it's flux. Yes, yes.
Just go back on that slide, please. Only until next day?
If they are inpatients. If they are not, then, normally what happens is, if you do it as an outpatient procedure, they are monitored for 4 to 6 hours in the unit. in the recovery unit of endoscopy.
What's the evidence for that?
Evidence was an NC pot study.
Yeah, but that's telling you 7-day or 30-day mortality.
No, but this was just, no, it was a detailed audit study, so there was a lot of information.
How long ago?
That was about, I think 2004 or 2005. It was quite an extensive, done over 4,000-5,000 patients. So,
Our practice is not like that.
no.
Very
Yeah,
different.
for outpatient ERCPs, like the way we do, if we do pancreatic work, we usually get them admitted overnight. And rest of all the patients, if we're doing an outpatient ERCP, if they're doing well after the procedure, we monitor them from maybe hour and a half to 2 hours.
Right, okay.
That's what we do too.
We normally, because the recommendation in UK is 4 to 6 hours post-procedure monitoring and then allow home. So if I do the list in the morning, then by 5 o'clock, both of my patients will be home. Like my list inherently was 2 p.m. in the afternoon, so normally we wouldn't send them home after that. The other problem that I have is that in our unit specifically, it's a large rural population. Some of my patients come from as far as 40, 50 miles. They travel on small country roads, so it might take them 1.5 to 2 hours to get to hospital. So if they live far and it's difficult access to the hospital, we admit them.
Yeah, obviously, as a patient who comes for a procedure, they're required to have a driver's license.
Yes, I mean that is certainly. I mean, you don't necessarily have to follow that, but that was the recommendation given to us. So during, after the procedure, it's important to recognize complications because of the drugs given, if they've had any perforation, like, if they complain of abdominal pain, which is out of proportion to the procedure. Most of the patient would complain of abdominal pain because of the distension caused by air. So you have to be conscious of that. You ask them to rotate the patient around in bed and, pass wind. If the blood pressure drops or the pulse rate goes up, and there's signs of acute hemorrhage, any sign of acute pancreatitis, you start feeling sick, vomit, or sepsis. So something to look for. And normally we give them information sheets, tell them if there's any problem to get in touch with their GP or go to the local ER. Right. Okay. Shall we talk about diathermy or क्या करना है? Sedation नहीं किया अभी, करने sedation पहले करने ठीक है. Oops. Right. Sedation and safety in ERCP. Now, again, one of the things that came out of the big audits that were carried out in the UK was that we suddenly found out that most of us were over-sedating the patients. And nowadays, this is an auditable item. I am audited on how much average midazolam and fentanyl arpacidine I'm using in my patients. And it is audited for patients above 70 years of age and audited for those below 70 years of age. So, with sedation, there is a definite risk associated, especially if you over-sedate your patient. And in the past, we found that most of our colleagues, especially the surgeons, were giving 5 to 10 milligrams of midazolam routinely for most of the procedure, whether it was OGD, colonoscopy, or ERCP. And similarly, 50 to 100 milligrams of pethidine, which in most of the cases was excessive. There was excessive use of reversal agents like naloxone and annexate. Nowadays, if you use a reversal agent, well, you have to use it if it's needed, but it is an auditable item. So it is a surrogate marker that you are overusing sedation. So, if you are using sedation, then there must be IV access in the patient. You should insert an IV cannula, secure. There should be supplemental oxygen. If there's any drop, pulse oximetry, BP monitoring is essential. ECG monitoring is not mandatory in all patients, but in some units they use it. We don't normally routinely use in our unit. It's only pulse oximetry and BP monitoring. All drugs are labeled and checked prior to administration. Normally, if I am performing the procedure, the nurses drop the medication, but we check the labeling on the syringe and we check the ampoules that the drugs are within their expiry date, and you actually read out loudly the amount of medication that are in an ampoule, so that there's no, so it's double checked, and usually give them again, NC-POD report, 2004 on therapeutic endoscopy, just 14% of our cases were over-sedated with very poor levels of formal training in sedation practice. So all this started, the double checking of sedation, the sedatives, the checking of the ampoules, everything started because of that. So we made it a regulation now. So a lot of good came out of these studies. And availability of BP and ECG monitoring, which was done at that time, most of the units were giving, pulse oximetry, almost 100%. BP monitoring was done in nearly 70%. ECG, about 50%, but as I said, not everyone does ECG monitoring. These are the patients who are high risk, elderly with comorbid factors. So now, obviously, the older your patients are, the higher is the proportion of the patients who needed reversal agent. And as I said, people were giving liberal amounts of sedatives and opioids during the procedures, and more of them were needing reversal agents. Up to 10% patients were requiring reversal agent. Nowadays, hardly ever they require reversal agents because we are very judicious in the use of our sedatives and opioids. Right, so main risk of sedation, as everyone knows, most of the time it is cardiorespiratory depression, hypotension, and it can be sometimes allergic reaction or anaphylactic reaction. So because of respiratory depression, hypoxia, CO2 retention, aspiration pneumonia, cardiac arrhythmias, hypertension or hypotension, sometimes if it is extreme, you can precipitate a myocardial infarction or angina. Sometimes you can get disinhibition because of benzodiazepines. There is usually benzodiazepine, especially midazolam, is associated with amnesia, antegrade. So they forget about the procedure, even they might have been shouting during the procedure. Nausea, vomiting is fairly rare. It used to be more common when we were using pethidine or morphine, but nowadays we've moved on to fentanyl. It is quite bad with Nubane or nalbuphine. Local reaction at the cannula site, it is more common, used to be more common with pethidine.
This antegrade memory loss, 46%, is this based on the current practice where you've gone down with sedation?
No, that was when at the time of the audit.
This is the audit?
That's it, that's the NC-POD. Right, now, usually as these drugs are given together, they've got a synergistic effect if you give midazolam and opioid. So we recommend that opioid should be given first. There are two reasons for it. If you give it first, then you require less of midazolam. Secondly, if the patient is going to go into respiratory depression or anything, they've only got one drug on board. So it is easy to reverse one drug rather than two drugs. So you give the opioid first, the fentanyl, pethidine, or nalbuphine, whatever you want to give. Wait for a minute, see any effects on the CO2, pulse oximetry, everything. And if that is fine, then you give your midazolam. Especially when I'm doing colonoscopy, I usually give the opioid first, do a rectal examination, set the patient up, look at everything, and then give them the midazolam if needed. So always give a bit of a gap between the two medications. Don't belt them in straight away. Right, it's just midazolam takes. The other problem is people tend to give high doses because they don't wait long enough for the drug to take effect. The moment they belt it in, they start the procedure. So if you give it a bit of a time, the drug would start working. I think we'll skip this bit, it's just clever stuff. The problem is most of the patients who require endoscopic procedure are high-risk patients. They are elderly, they are frail, they've got other comorbid factors, or they may have old age, obesity, liver cirrhosis, patients who got varices. So you have to be careful. Now, the cutoff point for most of our patients is 70 years. So if they're above 70 years of age, maximum dose of midazolam recommended is 2 milligrams. If I give 3 milligrams to a 70-year-old gentleman, then it is an auditable offense, and we have to fill in an adverse incidence form for that. Maximum dose in younger patients is 5 milligrams of midazolam. Similarly, maximum dose of pethidine is 25 milligrams in 70 years old. Right. Oh, sorry, I went back. Right. The other thing to be aware of is the fact that midazolam is protein-bound drug. So if there's any hypoalbuminemia, especially in cirrhotic patients, the effect will be more pronounced. If they are obese, it will be more pronounced. So they'll have over-sedation with it. Opioids are given for their analgesic effect. They can cause respiratory depression just like midazolam, and the effect is summative. BSG guidance, which is British Society of Gastroenterology guidance, is not to use doses of pethidine greater than 50 or fentanyl greater than 100 micrograms, and to reduce the dose by 50% in patients over 70 years of age. Fentanyl is a cleaner drug, quick onset of action, and after using pethidine for almost 25-30 years, I've finally converted to fentanyl now. But I never had any problem with pethidine either. It's lipid-soluble, fast onset of action, and the effect lasts for 2 to 3 hours. The only downside with pethidine was that most of the time it was associated with nausea and vomiting, which you do not get as much with fentanyl. And sometimes it would cause a local reaction at the cannula site. Now, the NC-POD inquiry again highlighted the fact that reversal agents were more commonly used in patients with cardiopulmonary complications. So the use of reversal agents is a proxy for over-sedation and an auditable outcome for the GRS. GRS is global rating scale, which we use to assess the performance of our endoscopist and the endoscopy unit. Reversal agents are flumazenil or naloxone, and you give them, if there is respiratory depression, it's usually presumed that it could be due to the benzodiazepine. So you give the flumazenil first, and the way to do it is 200 micrograms over 15 seconds, and then you keep on observing the effects. Because the effect is fairly immediate. If they are going to recover, then they would straight away. If that doesn't work, then you go to naloxone. If it's an extremist situation, respiratory arrest, then you give them both. Now, what we aim to do is, and in the consent also process, when you are explaining the procedure to the patient, you tell them that it is not going to be, they say that, if you give them sedation, you explain to them that it is going to be conscious sedation. They are not going to be knocked out as in a general anesthetic. They are going to be conscious, they are going to be talking to us, but the sedation will minimize their discomfort. So it's drug-induced depression of consciousness during which patients respond purposefully to verbal commands. As soon as the verbal contact is lost with the patient, that is a sign, that is a panic situation. That is something which one should be aware of. Because in conscious sedation, you are not required to maintain a patient's airway or intubate. They are able to maintain spontaneous ventilation. So generally, how do you find out if you've over-sedated the patient? Pulse oximetry is good indicator, but it is usually too late if you notice a drop in pulse in oxygen saturation. The first thing to notice is the loss of verbal contact between the endoscopy assistant and the patient. So if usually our nurses continuously talk to the patient, and so should the endoscopist be. But when you lose that verbal contact with the patient, then that is something to be alerted on. Right, okay. So that's important, right? It's the first sign of impending respiratory depression. So if this is suspected, so at that time when you lose the verbal contact, you should try to stimulate the patient by, shaking them or talking to them. and ask them to breathe. If there is respiratory depression, then you should use reversal agents sooner rather than later, before they get into. So you should give them flumazenil in the first instance, followed by IV naloxone, and if there's no change, if they're not improving, then you should consider assisted ventilation and call the cardiac arrest team. So do's and don'ts of sedation. Important thing in conclusion is check all expiry dates, all expiry dates of, check the doses, the formulation of the medication, register all vital signs before giving sedation. So before you give the first dose of your sedative or opioid, you should check their pulse, the oxygen saturation, pulse rate, and blood pressure. That's all standard given. After you are given the drugs, then you monitor the pulse, the oxygen, and blood pressure. And allow adequate time for the drugs to take effect. Don't sort of belt them in. And work as a team with your nursing staff to ensure adequate monitoring, and keep verbal contacts. Don'ts of sedation. Don't give midazolam before opioids. Don't forget to continue to monitor observations throughout and after the procedure, and do not ignore the information given to you by the nursing team. Because sometimes I usually see, especially our trainees, the alarms are going off, everything's going off, and they still continue the procedure. If for any reason, because most of your pulse oximeters are set at certain levels to give off the alarm. So if your pulse oximeter is giving off alarm, or if the nurse is, getting concerned about your patient, you must pause or stop your procedure and attend to the patient rather than continue. Right. Now, just some clinical scenario. You've got a 34-year-old man, history of alcohol excess and intravenous drug use. So he's an IV drug user, excessive alcohol, he's abused his body all his time. He has chronic pancreatitis with pseudocyst, tolerated previous OGD poorly, listed for ERCP. How would you approach this patient? It's for you people now to talk back. Okay, fine. Right.
Patient has tolerated previously poorly.
Yeah.
So I think the opiates were first, then followed by
Okay. Opiates first, then followed by propofol. Okay.
I think it should be under DA.
Pardon?
Under
Okay, fine. Yeah, I mean, that would be the politically correct answer. But usually in our unit, we'll do it, one of our experienced endoscopists would perform it, and we'll still give it a try with, a combination of opioids. And but yes, it might come to a general setting.
I don't do any pancreatic therapy or resuscitation. Anything like this will not be done.
Will be, so it should be a...
Especially, the word of caution here with pseudocyst is that the patient
will require a...
patient should be intubated, because they sometimes, cysts, when you're draining them, there's a lot of fluid that comes out, and there's a risk
of aspiration.
Yeah. So with this history, I think, even without this history, just the fact that we needed to drain pseudocyst or and this is our practice.
Yeah.
All pseudocyst, all pancreatic therapy is done under sedation. I have not done sedation.
And these alcoholics, they usually end up requiring.
Yes,
The other problem is
he's an IV drug abuser as well. So you'd require very high doses of opioid if you need to. Yeah.
High tolerance.
Yes.
even the first case, if I take a step back, and this patient came to me first time, I'm not touching under sedation previous. Anybody who's alcoholic, especially IV drug, no way, I'm not touching. Go to the anesthetist, let them sort it out. I'm only going to focus on my endoscopy, they'll take care of it. It's not my headache. And if OGD maybe, you can do it, not a big deal.
But ERCP is a major procedure.
Especially you've got a complicated chronic pancreatitis patient, you don't want him moving at all.
Yeah.
It's a
And if you are
thing.
performing any therapeutic procedures, then yeah.
So that's it.
And what these recommendations for 5 milligram of midazolam and
No, that is the general recommendation. In, special situations, we would go above that, but that is auditable. So I have to explain why I had to give that dose. That's, nothing. But generally, that is just to discourage its unscrupulous use. Generally, a patient who would require more than 5 milligrams of midazolam, most of the time will be done under GA.
And this is for all type of endoscopic procedures, including ERCP or?
With ERCPs, we are a bit more liberal in sedation, but as I said, if we are requiring more heavier sedation, then I would do it under GA. I mean, that is standard practice with us.
I personally feel if I had the choice, I would do all ERCPs under propofol. Life becomes very easy. The last thing you want to do when you're doing ERCPs, especially if they're even a little bit complicated, is to worry about whether the patient is talking to you and what's happening to the lungs. I really don't want to know that.
But then again, if you are doing...
But obviously that's the world where we live. All these patients I know are done under propofol, under the supervision.
But if you are doing every endoscopic procedure routinely under GA, then you are increasing the risk of GA to the patients, and it doesn't become any more different than doing a surgical procedure. So generally, whatever procedure we can do with sedation or conscious sedation, we do that. A lot of our colonoscopies nowadays are done without any sedation of any sort. We just do it.
I don't have a problem with colonoscopy.
But yes, ERCP, yes, that's different. I agree.
Especially
But
if you've got a training unit.
yeah.
You're training people, it's very uncomfortable for the trainer as well as the trainee and the patient is actually.
Because the overwhelming majority of our biliary work is done under sedation rather than that.
Too, but I'm just saying, if I had the opportunity, like he has, I would prefer doing it. And certainly they have shown that their practice is no less safe than what we do with sedation. And not only that, but their procedures become much easier.
Right. Case number 2. 60-year-old woman, mitral valve replacement on warfarin, abdominal pain, abnormal LFTs, and recent but resolved mild jaundice, gallbladder stones, 10 millimeter CBD on transabdominal ultrasound scan, suspected stones in the CBD. How do you approach ERCP in this patient? Oops, sorry. So 60-year-old woman, she's got mitral valve replacement on warfarin. What should we do?
We have to stop warfarin, switch to IV heparin, hold that heparin 12 hours before the procedure, and for sedation we can do it.
Acha.
Why not take a step back? Do we for sure need an ERCP? How do we know the stones is not passed? I would do if I had the option, I would do an MRCP.
Okay, fine. Yeah, that's fair comment. Yeah,
MRCP,
because
if
it is a high risk
MRCP
procedure.
is clear, then my job is done. I'll pass the patient over to the surgeon. I don't have to worry.
Okay,
That was my.
Yeah, that's a fair comment. But if the MRCP shows stones, then you are screwed.
Yeah.
Okay. So what do you do then if your MRCP shows stones? If that patient had aortic valve, would your management be any different? Prosthetic aortic valve. How? Replacement.
Higher conditions and higher risk. Conditions and risk are both higher.
For aortic valve or mitral?
Aortic,
Aortic is higher. Okay, fine. Good. Good.
it's most necessary we start the warfarin and we start the low molecular heparin. If patient is on mitral valve replacement, is a low risk condition, high risk
Achha.
procedure ERCP.
Right.
So not necessary we start the warfarin only 4 to 6 hours and at the end of the procedure you can start it.
It's a very good explanation, but wrong. Right. Aortic valve, even a prosthetic aortic valve, is a low-risk condition. You can easily stop the warfarin without any consequences, right?
It's a hijack.
It's a hijack.
Flow
Yeah.
through the aortic valve is much
So,
more high,
the main,
stronger as compared
yeah.
to this. So it's a less risk of
yeah,
thrombus on aortic valve as compared to
mitral valve.
So you told everything up.
So if you have a mitral valve, your mitral valve will seize. Even, it can send off emboli, but it can even stop working, just become clotted, right? So that's even more dangerous. So with mitral valve, you cannot take, it's a high risk condition. So you have to keep them on anticoagulation. So you stop their warfarin 5 days before the procedure. We put them on low molecular weight heparin, which is enoxaparin that we use, a subcut. In the past, we used to put them on intravenous heparin, which was a bit of a pain. But nowadays, everyone uses enoxaparin, or clexane, as we call it. And on the day of the procedure, you don't give the heparin. You give it later. So that's how.
Let me change the scenario a little bit, Waqar.
Okay.
This patient needs urgent ERCP because there is a stone impacted at the distal end. This has got acute pancreatitis.
Right. Okay. Fine. Yeah. How would you do that?
Warfarin is there.
Yeah.
Now what are we going to do?
Yes. And that's a very common scenario.
It is. Yes.
It's not like
You don't have 5 days for preparation.
Yeah.
That's what I'm saying.
One at a time.
I would like to go for ERCP
Okay.
and just place a stent.
Okay. Fine. Okay. Fine. Good. That's how you make multiple choice questions. Any other
I
option?
think if FFP is very procedural,
Right.
avoid sphincterotomy,
Okay.
place a stent, and then electively the whole thing follows, and then later on we can give.
Okay.
In this scenario, we can see the INR range. What is the optimum INR?
Well,
Then,
if you have got a mitral valve replacement, your TTR, which is target therapeutic range of INR, should be above 3.5. It should not be below 3.5. So that is going to be a very, sort of thin blood. Right. Okay. Any other offers? I think the easiest thing to do is to go down and put a stent in.
Yeah, I think that's.
and you don't have to give FFP.
You don't have to give, because if you give FFP, you are putting your mitral valve at risk.
The point I raised was that can you do ERCP in somebody with a high INR if you're not going to cut?
Yeah.
And the answer is
The answer is yes.
That was the.
Because if you give FFP, then you have to anticoagulate them again, right? So it is not an ideal situation. But you can, yes, put a stent in and that will do the job. Good. 68-year-old man, abnormal LFTs, EUS shows 13 millimeters CBD with stones on aspirin and clopidogrel for ischemic heart disease, attempts for day case ERCP, normal full blood count and clotting. How do you proceed?
There is no emergency, we can stop this and after 3 days we can
In our practice, most of the time we consult cardiologists. There is no acute.
If there's no cardiologist, what do you do?
Then we do ECG ourselves.
Okay, fine. So if the ECG is
I
normal,
have a problem with that. Why is the patient on aspirin and clopidogrel if there is no cardiologist?
the cardiologist has gone home. Cardiologist, you don't need a cardiologist to start aspirin and clopidogrel.
ECG ourselves, if there is no acute insult, then we counsel it, then stop, and then we go for.
The cardiologist will be sweating if I change this scenario by saying the stent was placed in this patient last week.
Like the last week, then what
Okay,
you-
and the cardiologist is going to sweat even if you talk about, you even mention, say to hell with the, I'm not
Yes, sir.
letting my patient go because of the heart. You saw it with GI.
Yeah, if it's an elective procedure,
Most of
then
the times clopidogrel is stopped and aspirin is continued.
yes, yeah.
So there is
and it's depends,
then,
when ischemia is developed, when the MI is developed, let's say more than 1 year, there's no need to stop a clopidogrel and aspirin. Less than 1 year, within 6 months, we can stop a clopidogrel and aspirin can get.
Yeah, that's correct. Yeah. Okay. Good. 82-year-old woman, metastatic pancreatic adenocarcinoma, frail, marked weight loss, booked for ERCP and metal stent insertion. SEMS is self-expanding metal stent. How would you manage sedation in this patient?
After you talk, it's easy.
Yeah. Right, okay. Less than 2 milligrams of midazolam, probably.
My only concern is if I stop here in Pakistan and say, well, metastatic adenocarcinoma in an 82-year-old. Do you want to put a metallic stent? The patient has said, I'll have to sell my motorcycle and maybe sell some other things to get that metallic stent. I'll put a plastic stent.
Right, okay, that's it, folks. That's all, folks.
That's something that you need to take into consideration when you're sitting in this system.
And if metastatic cancer, do you really want to do a ERCP in a 82 years old person?
Yeah, if they're obstructed. If they've got obstructed contact, they're itching and all symptomatic.
Yeah, it's symptomatic.
Yeah,
I'm talking about asymptomatic.
No, symptomatic. No, asymptomatic patient.
I don't care if they're
Whatever the bilirubin is, if they're asymptomatic, you can just the last few slides were just to wake you up before we get on with what we were doing yesterday. That's right.
Okay, she is a 55 years old lady, known case of diabetes mellitus and hypertension, and she presented to us with complaint of right hypochondral pain for about 1.5 months. Her abdominal examination is normal. Her LFTs are total bili of 0.78 and alkaline phosphatase of 193, that is raised. And ultrasound abdomen was carried out that showed dilated intrahepatic ducts with gallbladder stones and a dilated CBD of 7.4 millimeter with a calculi in the CBD.
Right, okay, fine.
I should say for ERCP.
Right. Right, okay, you can. Hello, can you hear us there?
We can.
Right, okay, thank you. Good. Right, we are just about to proceed now.
Okay.
Haji. Right. Good. Right, suction check kar rahe beta. Okay, fine. And okay, check the lights. Light on the ignition, lamp on. Check the light. That's okay, good. Right, and put lubricant on.
So what he's trying to do is like check your equipment before you start the procedure. Check the light, check the elevator, and make sure suction is working. You don't want to do that while
just
the scope
lubricate
is
the
inside
tips.
patient. So check
That is the one which is going right. Okay, so gently without covering the lens. Right, okay. Right. Right. Okay. Right. Ready? Thank you. Always check with your anesthetist before you start. Right. Chalo. Right, okay, so that's good. Well done. Good. You can look there as well. Yeah? Okay. One of the important thing is that your lens should be clear, right? So if you, then it's okay now, but it was a bit of a, right. Right. Okay, now you need to know where you are at the moment, right? I know, okay. Just blow a bit of air. Yeah. No, you are blowing water now. Just if you touch, no, just a second. If you touch the scope like that, then you blow air. If you press on it, then it blows water. I think it, that's why. That's why you check your instrument before. Ab theek hai. Theek hai? Right. Okay. So that's good. Right. Basically, जो है आप जा रहे हैं scope तरफ, you should be aiming toward the right side and lower down. Yeah, so follow the groove. Just suck that little. That's it. Okay, that's good, right? Yeah, very good. Just clear your lens because it's very important to maintain good visibility, right? Okay, so yeah, you can see the pylorus there, and it should look like a setting sun, like this. That's it. Right now, aim towards the 4 o'clock position. That's where your duty. Don't rush. Don't slow down. Slow down, beta. You don't get anything by rushing apart from getting a perforation. So slow down, proceed gently. You are dealing with live human tissues, right? Okay. So just beware of that. It's not a dummy we are doing it on. Yeah. Now, yesterday, if you saw us, we were asking you to hold the scope like that, not to go it like that, okay? So always be in the right position. Okay. And the other thing is, don't force your scope. Let it go gently, right? So, yeah, that's fine. Right, okay. No, just a second. Don't go into, wait, just calm down, right? Don't go into such an extreme position. The scope is turned like that, you are twisted in yourself. Always look comfortable and nice as the scope is. You see, you are in a real, you can't do an ERCP with a scope like that. Okay? Or you say you can cause damage there. So it is locked, it shouldn't be locked, right? All the knobs should be relaxed. Just a second. You can't do an ERCP with a scope like that. It is impossible. Trust me, right? So the thing to do is, for a main stage, you should be relaxed. Don't give talk to the.
If the beads are
Let
locked,
me get it back into neutral position. See, when you enter the stomach,
the scope is going to be like this, and you're never going to be able to get a better position. Allah, straighten the scope.
okay? Follow the gastric fold, right? Like that. I'm not twisted the scope, I'm not like this, okay? So just be normal, right? The scope is in just a second. Let me show you. You might bother. Just go neutral, right? You can see the pylorus there. Just intubate.
And if you are having a trouble, if the stomach is too big, full of air, you might have the trouble like that.
Basically, if
so
you distend your stomach too much, it makes it a bit of a problem.
After you get to the pylorus, and that would move the scope very easily in there. And the best way to deflate is like pull it back, and you want to take the air out of the fundus, not from the antrum. Because if you take it out from the antrum, it's going to just collapse there.
I think so. Right, okay? So you go into the duodenum, it makes it so much easier. Don't push or do any torque steering here. Torque steering is for colonoscopy, not for ERCP, right? So look, my scope is straight, I am not twisted in any posture, I am comfortable, I am relaxed, and I am talking to you, right? And there's nothing, the scope is not twisted or anything. We are in the second part of duodenum now, right? You can visualize the papilla there, right? Now you can.
So this is the, when you add the duodenal apex,
Okay,
it's the
yeah,
same
yeah, you put
concept of
right and lock.
sunset. You look for the
When you are
duodenal
going
lumen,
into the
and you have to
duodenum,
bring the
through the
scope back,
pylorus,
like
it should
in
be
the
unlocked,
position.
neutral.
The lumen
now,
is
withdraw your
just
scope,
right at the
right?
sunset, just like you had with the
okay.
pylorus. So you cannot keep looking at the whole lumen and push. So you have to make it like a sunset, the second part of
wrong.
the duodenum. Did you notice that? That's how the position was.
Okay. No, it's not right. Okay. No. No. Okay. Let me do it for you. Right. Okay. Go in. right, okay. But it will fall back into the stomach again, right, okay. So that usually happens if your position is not correct. Right, okay. So again, you go back to neutral position.
Every time you fall back into the stomach, you forget to unlock the wheel. So just make a habit. You are just trying to get back in quickly as soon as possible. Just make a habit that you have to unlock the wheel for scope to get straightened for you.
Right. So you find where you have to go, right? Okay. So I'll just. It's good to take the air out because if your stomach is over-distended, it's difficult to traverse the stomach. So within 2 seconds you are back in the duodenum, right? So we go back into the second part of duodenum.
You see how
right?
that's at sunset
right?
when
Okay.
you're moving
So
that?
comfortably, now you put your thing in right lock, and then as you are
even
out,
pylorus and
see,
even from the duodenal
I'm doing exactly
apex,
the same what we should
like
done,
duodenal
right?
sweep,
So now
that
you
has to be
are
also at the sunset for
scope,
scope to go.
and you get in position, right? Okay. So as we said, the important thing is position, and look at my scope. It is straight. I am holding it up in a comfortable position. It is not twisted or anything, and we are trying to home in on the papilla. Okay. So there you go.
Can we see the fluoro image?
Right. Okay. So now get yourself into position. Stop unnecessary suctioning, and check your position of the papilla. You can turn yourself a bit right, do some movements up and down, see what you can do with the papilla. Yeah, that's right. Okay, good, right. So yeah, there are fluoro set kare bhai. Ha, thank you. Okay,
so
you know where the
position
papilla
of
is
the
now.
scope. It's very
That is
reduced
good,
scope.
very good. Okay, it's a bit overhanging, and you may have to lift it up with the cannula to probe it a bit. Okay, but do very gently. हाँ जी, वार लोडेड है वसीम? अच्छा ठीक है, वो भी कर दें, वो क्या है अपना कॉन्ट्रास्ट भी वो कर दें। अच्छा रेडी है, सही है, प्राइम्ड है, हाँ मुझे प्राइम्ड है, ठीक है, गुड, ओके, हाँ हाँ। You are a bit too close to the papilla for comfort. So just, yeah, oh, sorry. हाँ भी सही है, ठीक है. Okay.
Just suction.
दरअसल मामूली सा सेक्शन करें कि वो हो जाए
And
आपके.
if you're still having a lot of
ठीक है,
problem with that, you can just wash it with water flush. We sometimes, if it's too much, you can use a Smethicon or Mylocan if needed, but you almost never need that in ERCP.
थोड़ा सा आपको वो करें ताकि you should get a bit of more leeway on it, yeah, because you are too close to it.
So it's too close to move away from the papilla. You have to move the big wheel away.
You need a bit of, okay, fine. Just look at the papilla, okay. You are going at the wrong, okay. Lift gently, lift. It's a very tight approach you are getting it on, because the problem is here you are doing it blindly, and that is bound to have problem. Now disengage, withdraw your cannula, try to get a better position, because you can't,
Position.
Right, okay.
You have to get
that is not
better
a way to
position
do it,
before you touch the papilla. Every time you touch the papilla, you irritate it.
Let's see if I can get you a better
spasm,
position, then you can try.
And you make it bloody. The next attempt is going to be difficult for you. So before you touch the papilla,
मतलब
get
पूरा
into the
ज़ान
position.
सेट किया का ना लोगों ने वैसे
Spend as much time as you need to get into the position.
So the only problem with the papilla is it's a bit overhanging, ठीक है? No, लोगों ने scope रहता है धरावर का, ठीक है? No, I'll just, right. ठीक है?
to come from
That just
bottom
gives you-
up. You can't go from top down for cannulation.
Right. That's the position. Oh. Now. Look on the withdraw. Yeah. Push your scope in a bit. Yeah, down. Or right, okay? Now. Yeah. Use the up and down wheel to adjust your position. Try not to cannulate as yet. You are not in a good position to cannulate. Use your position to up and down the wheel. Oh, that's better. Because if you try to cannulate from an impossible position, you can never get it. Yeah, that's better. Okay, fine. Right, yeah, that's okay.
There are few folds on the papilla, so what they will have to do is get into a position, engage
No.
it.
You are
and
doing.
then
Don't
use
drop the cannula
elevator
against the
to lift it
papilla.
up to
Yeah.
get into the.
Push it away from you. Yeah. Now, Gora, it should be in the center of your field. It's in the periphery. Periphery, you can't do a cannulation.
then
And push your
elevate
scope
to
in a bit to
straighten
see if you can
Yes,
get a
do
better
that.
access on it. Right? No, not that much.
technique would work here.
That probably was a better position there. Yeah, okay. The second. Yeah. With this angle, you can never get into the CBD. You are only going to perforate the papilla towards the lower end. So withdraw your cannula. Yeah.
Here, if you
No.
lock the small wheel,
It still wouldn't
that's,
go. Because if you look at the simple physics of it,
helpful to you.
your
It's not
cannula is
helping.
not pointing in the direction
So
of
you
the
have
CBD.
to unlock it. To
But
get
you
into a
can't
better position.
cannulate in this position. You have to improve your position. That's all.
Yeah, that's the first wheel.
जी वैसे
we
देखो
don't
ये
have
जब
general
इसको
GI.
मूव करो ना तो
I
कैनुला
don't
विड्रॉ
do- I
करो
very
उसको रब
rarely
करता है
do
तो इट विल
EGD
मेक इट डिफिकल्ट फॉर यू
colonoscopy. Like only I do those where it's a failed colonoscopy, or it's a endoscopic resections, or it's some VIP.
हाँ शाबाश मेन आपका एम इस वक्त ये है कि यू give yourself a bit of distance between yourself and the papilla and bring it more to the center of your field. It is at the periphery of your field where you cannot safely cannulate. ठीक है? That's the whole exercise. हाँ, that's a bit better. Yeah. थोड़ा सा इसको हाँ वो करो yes और अपने आप को इधर मूव करो. That's better. ठीक है? ज़रा सा इसको distance दो. Push the scope in a bit. देखो एक जो है ना आप एक मैन्यूवर करते हो ना तो उसके लिए यू डोंट हैव टू बेंड उसी पोजीशन में आप मैन्यूवर किया करो बेंड करोगे तो वो सारा पोजीशन आपकी फिर वो हो जाती है ख़राब हो जाती है योर कैनुला इज स्टक ऑन द म्यूकोसा दैट शुडंट हैपन विड्रॉ योर कैनुला हाँ शाबाश गुड नहीं आप फिर उसको गलत कर दिया हाँ ऐसे दैट्स बेटर हाँ ये सही है हाँ जी नहीं तो कैथेटर नहीं जाएगा ना बेटा कैसे जाएगा आपका पोजीशन है ही नहीं यही तो आप मतलब दिस इज हाउ आपका एक्सरसाइज है ना हाउ टू गेट योर सेल्फ इन एन ऑप्टिमम पोजिशन बाद वक्त इट्स वेरी ईजी समटाइम इट कैन बी अ बिट ट्रिकी सो दैट्स द होल पर्पस ऑफ यू नो शोइंग यू हाउ टू डू इट ओके तो अभी हाँ हाँ दैट्स बिट बेटर ज़रा सा उसको अंदर पुश करें स्कोप को दैट्स बेटर हाँ अब नाउ ट्राई इन दैट पोजिशन ठीक है और जैसे आप हाँ नहीं डोंट पुश इट इन ना आराम से उसको जेंटली टच करें पहले इसका टच होता है यू कांट गेट द कैनुला इन वन गो ठीक है ना तो उसको थोड़ा सा वहाँ पे आपने रखना है यहाँ पे ये जो आपका ये रेड स्पॉट नज़र आ रहा है ना इधर आपको वो करना है, फर्स्ट टच देना है और उधर से आपने फिर उसको इंगेज करके पुश करना है, मतलब लिफ्ट करना है। हाँ या अच्छा, कैन्यूला एडवांस करने की बजाय आप उनको कह सकते हैं कि वायर एडवांस करें। हाँ, क्योंकि कैन्यूला तो पूरा उसका सत्यानाश करेगा, नहीं इट्स नॉट इन अ गुड पोजीशन। हाँ, इसको हाँ विड्रॉ करो बेटा, शाबाश। ठीक है, लेट मी हेल्प यू। ठीक है, नाउ ट्राई। क्या नहीं नहीं कुछ नहीं, सही ठीक ठाक है। अच्छा, लॉक यहाँ का आपने? अच्छा नहीं, हाँ हाँ लॉक यहाँ पे तो आपको पोजीशन, मतलब वो जो कहते हैं ना कि आप लॉक ना करें तो वो एक्सपीरियंस एंडोस्कोपी से तो उसके लिए ठीक है, आप लॉक किया करें। हाँ इसको बेटे सर, आप पेपिला को ऐसे नहीं वो कर सकते, यू हैव टू, या तो जैसे उनने पहले वो दिखाया था थोड़ा टिप ऑफ द गाइड वायर यूज़ करें, गाइड वायर का टिप ज़रा निकाल दें बस इमेज के लिए। हाँ मामूली सा, हाँ अब इस यू ट्राई टू गो थ्रू दैट, क्योंकि पूरा कैन्यूला आप इसमें नहीं डाल सकते इस तरह, यू हैव टू। या ठीक है, हाँ अब जरा सा उसको, हाँ दूर, हाँ ठीक है, हाँ थोड़ा सा ऐसे वो, या अप डाउन में, हाँ व्हील यूज़ करें जिससे आपको ज़रा सा डिस्टेंस मिले। हाँ हाँ, अब वायर थोड़ा सा एडवांस करें, हाँ ठीक है ठीक है, अब एंगेज करें इसको, हाँ शाबाश, इट्स अ बिट लो लेकिन,
And you can still cannulate.
हाँ
Can we just show the X-ray position, please?
X-ray position is good.
Oh, you saw it because some of us came late, so. Oh, fine. Thanks.
Okay. नहीं जाएगा बेटा। I think I'll take over because it's been quite a bit of a time. ठीक है? Let me see if I can thank you. वो अपना थोड़ा सा वायर निकालें। It's overhanging a bit. I'm trying to do it with a wire. Try करें अगर मशीन में नहीं, अच्छा ओके आप ट्राई करें. नो अच्छा ठीक है. एक मिनट. कोई एट्रोपिन जरा दे इसको करने के लिए. Calm down.
If this position is not working, do you
No.
want to try the long position?
I'll just trying to get a bit of give a bit of anticholinergic to see if you can calm down the duodenum.
Okay.
Yeah, okay.
It's going to the here. The direction is here. Direction.
थोड़ा सा इसको बो दें. एक मिनट.
So you have to do something to actually bring that direction down.
कोई एट्रोपिन. हाँ हाँ ट्राई करें. यार नो 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 नो. नहीं, it's in the wrong spot. वायर एडवांस करें.
So here you really need to disturb this thing so that it
नो. हाँ नो. अब ठीक है. इधर करें. नो 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 नो.
One other thing you can do is stay right here. Fill up with the wire, and then ask the tech to go the spindle. It's getting in the right direction.
Green tea?
Direction is getting better,
No.
but I think he needs to go the patella and outwards. And that's give a back direction. Yeah, this looks better. Pull the spindle and pull towards you. So that will straighten the patella.
Okay. एक ख्याल आराम से. Relax the bow.
Yeah, you have to engage it
ठीक है.
and then go and you pull the spindle towards out. What that's going to do is that's going to straighten the patella and get in line up.
बो करें थोड़ा इधर.
So what that does is when you go it, the direction of the spindle goes this way, and when you pull it out,
Okay.
what that does is it
Withdraw from that.
everything this way and aligns in the line up.
अब यार. नो नो. अच्छा ठीक है. छोड़. एक
what happens obviously is when you manipulate, you will have some edema there. And longer you manipulate, the more the
इधर.
After my, it's
No,
kind of
no, no,
my
no,
rule
no.
is that
Let me have a little look.
I touch the patella 4 or 5 times in one direction, in one position, and if it's not working, I change the position, either go into the long position or go into semi-long position to get a better angle.
इधर बो करें थोड़ा सा. No.
Well, I think bile coming out really doesn't mean anything. Bile is sometimes it could be deceiving. Bile is coming out, but the cannulation still could be very good.
Yeah, doesn't mean that it's
Bile
Yes.
it just tells you that you have an orifice.
Yes. You are in the right.
Should be able to get it.
Yeah, you are in the right place.
Do you have number of times you attempt
Either.
or time that you give before you say, well,
Just try for
get
it.
in, I'm not going to get in, I know that I'm not.
Yeah, it's. I have a set up time for myself. If like as I said, I'll try it for
Advance
5 minutes in
करें
one position. If that's not working, I'll change
direction
the
नहीं है.
position and maybe try up to 10 to 15 times before I decide that I need to go for needle knife or something else, or at least get one of the ducts in this position. Sometimes it's easier to get a pancreatic duct, get the wire in there, put a stent in there, or do a double wire technique. I like putting the stent in there. That way my pancreas is safe. I don't have to worry about that. And then I need whatever, I try to cannulate one more time over that stent with the sphincterotome. If that doesn't work, then I'll go to needle knife, which should not happen quite often.
वो हाँ थोड़ा सा बोल रहे.
In my opinion, yes. Not
Yeah,
for
yeah,
the
let's try
patients
for it.
with the pancreatic cancer. I don't think there's
Yeah.
a need for that.
Yeah.
These tumor
It's
or
pretty
any
bad.
cancer-related patients, I don't think you need a pancreatic stent to do a needle knife. But needle knife should be used only 1 to 2% of the time, or maybe at most 3% of the time. If you are using a needle knife in 15% of your cases, you need to change your approach. You need to, you're doing something wrong.
इधर try करें. Nope.
You can inject a little bit to get an idea, because I showed a video yesterday, and it's a usually very tight stricture. That's the case. But if nothing is working, and in those cases you can do a needle knife, freehand needle knife without a pancreatic stent. But other options is which I would not talk to you about that. I would never recommend. There's a technique called fistulotomy. Fistulotomy. And you just dig into the bile duct from the duodenal wall, but you should never attempt that unless you know exactly what you are doing.
You have a slightly different pattern.
Yeah, you can, but in the pancreatic
What is the
cancer,
bile
I would
duct?
not suggest to do a fistulotomy in this simple bile duct stone case. And you need to know exactly where the bile duct is to do the fistula. So you have to have a really good concept and have a sixth sense, what I call, to get an idea where the bile duct is coming.
This is a modified pre-cut.
It is a modified pre-cut, but you are not just going, you're not using the ampulla, you are using the space above the ampulla. Yes, that's not.
Obviously, you have a nice UC ampulla, it becomes very good.
And usually,
Relatively comfortable.
relatively comfortable, and the only, as I said earlier, I would recommend fistulotomy only for pancreatic cancer patients. And the reason is usually it's safe, those patients are, it's safe to do in those because it's all tumor up there and less risk of perforation.
Yeah, we don't.
Is that
We
right,
have a
sir?
slightly different. I don't put stents in all needle knife. I feel that
अगर स्क्रीन करो.
your limitations and
Yeah.
your expertise. There's no point traumatizing the
Advance?
user when you
नहीं?
you're not likely to get it. And a lot of bad press that was given to needle knife because of pancreatitis is because people would have the ampulla for 20 minutes, 25 minutes, and then go for needle knife, and then the blame used to come on needle knife, not the previous 25 minutes.
So that's exactly, that exactly is right.
I
Yeah.
know after 5 times that I'm very unlikely to get it. And I know what my safety,
Is it?
task is going to follow are with needle knife. And when I
Try
look at
करें.
both of them, I know that doing needle knife at a certain time is much safer than me continuing.
वो Queens?
It's all dependent on the experience.
Nope.
If you get into the pancreatic duct time and again,
Okay.
this scenario you're not getting into very
कैसे ट्राई करते हैं? नहीं अभी नहीं, मतलब जब तक वो ना सब निकोजल वो हो जाएगा कॉन्ट्रास्ट। ठीक है, तो लेट्स ट्राई डायरेक्टली वो वायर आउट करें थोड़ा सा।
And yes.
करें वायर? No.
Okay, it helps you find the CBD. Pancreatitis risk is reduced. And when you really need to put a pancreatic stent, if you're not interested, you're not getting it. But in this scenario, when we haven't got a single duct at the moment, we're not experiencing that.
एडवांस करें वायर? इधर? No.
What I'm like, if something is not working for you, it's just try something else, because there may be a little problem. Keep doing the same thing again and again. If it didn't work, chances are less likely that it's going to work.
No, the bayan patakar. Hello. एक मिनट नहीं आया, विड्रॉ करें थोड़ा सा, इधर एडवांस करें। ओके छोड़ें, विड्रॉ। ना देखिए लोगों ने एक्सेस से बगेबल साइड से 9 o'clock पोजीशन पे गए। I'm just trying to approach it from that side. ये इधर इधर ट्राई करें मेरे। हाँ थोड़ा सा बो करके वो चेक करें। हाँ नहीं ट्राई करें। हाँ 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 पीलिया। अच्छा इसको विड्रॉ, हाँ विड्रॉ कर दें पीलिया।
Waqar,
Yeah.
there's a query here. Khalid wants to know, if you've now got, it's a difficult cannulation, you've finally got into the pancreatic duct.
Yeah.
In your practice, do you normally put a pancreatic stent at this stage and then proceed, or you don't?
Not necessarily, unless I'm going repeatedly into it. Because you can cause a false passage and then you do a one-off, I wouldn't really. Yeah. It's But yes,
No, it was
that's the point
mainly
here.
because you see we have been manipulating the ampulla.
Yeah.
So the point that was
Yes,
being
yeah, I think that probably would be yes. Just to prevent pancreatitis, yes, you might do that. Yeah.
okay.
Yeah, okay. If you look at the axis of the CBD, it's at rather 10 o'clock rather than the 12 o'clock position that we normally would. So there's a bit of a. अच्छा, अब थोड़ा वो करें. हाँ. कम करें. अब एडवांस करें. हाँ, बस ठीक है, वो ठीक है, थोड़ा सा एडवांस कर दें बाहर. हाँ, नहीं हो रहा, अच्छा ठीक है, मैं थोड़ा सा कैमरा विड्रॉ करता हूँ. हाँ, अब आप करें, स्क्रीन करें ज़रा. हाँ, ठीक है. हाँ हाँ, पेन कर. अच्छा ठीक है, इधर ऐसे करें, लीव द वायर इन, इसको वो कर देते हैं, स्टैंड कर देते हैं. हाँ ना ना, मतलब मकसद स्टैंड को you can leave the wire in there and you can then use a हाँ, you can use that, you can हाँ. अच्छा, अब जो है तो इसको वो कर दें. हाँ, अब कितना 5 फ्रेंच है. हाँ, 5 फ्रेंच कर दें. हाँ ठीक है, चलो. हाँ, पिकटेल, सिंगल पिकटेल. हाँ ठीक है. हाँ, रेडी फॉर चेंज. ओके, आराम से. ओके.
The Japanese used to place this wire over here and try another wire.
You can do that as well. That also helps. So, matlab we'll put the PD stent in and then just get on with the procedure because that probably. Third.
Yes, Khalid. Sorry, Waqar.
Yes, sir. It's just that Kamran has raised the issue that, would I do a double wire technique or use a stent in? I mean, sometimes it's quite acceptable just to leave the wire in the pancreatic duct and keep attempting the CBD.
Yeah.
And then you can put a stent in the pancreatic duct at the end of the procedure.
Yeah, that's pretty safe and very
that's
useful.
Pretty safe, and usually the stent, the advantage with that is that the stent doesn't interfere with your cannulation.
I think
sometimes if the stent is getting in the way, then it might be a problem.
I think you're totally correct.
वसीम ऐसे करते हैं कि स्टैंड बाद में डाल देंगे, फिलहाल वायर छोड़ देते हैं, डबल वायर पे कर देते हैं. So that is a fairly relevant way to do it. Yeah. Now you've got a guidance there, and you can see bile coming out as well. So we'll just try and go above that. See. हाँ, कैंसर डाल दें. रोटेड है. हाँ जी.
Waqar,
जी जी.
this Pakistani Pepula is teasing you a lot. I can see that.
I know. I think there's a slight difference in the feel of your scope as well, so that might be my excuse. Right, okay, let me give a bit of a right, okay. ये थोड़ा सा बो करें इसको बस. हाँ, दैट्स बेटर. अब कैंडिडेट का वायर एडवांस करें. नो नो, अच्छा ठीक है. खैर, इसको थोड़ा सा वो कर लेते हैं. अच्छा,
shortening prefer
जी
big wheel or this shortening of scope or big wheel?
आप ट्राई करें.
Bringing it close.
You can use both, whichever works. इधर हाँ अच्छा इधर थोड़ा सा गाय वो के पता लगे. अच्छा एक ठीक सही है. थोड़ा सा गाइड वायर एडवांस करें. नो अच्छा अब इसको बो करें. रास्ता वो हो रहा है फंस रहा है बीच में. बो करेगा. अब वायर एडवांस करें. नो ठीक है. अच्छा ना लॉन्ग कितना सर मैंने विजिबिलिटी दूंगा नहीं. थोड़ा सा बुक करें इसमें. एडवांस वो हाँ अब
I think, Dr. Wakar, you're trying, I don't know if you were in your hospital, you might have done a needle knife by now. But
yeah.
I think you are trying to
I'm trying to
show
avoid it in
everybody.
front of the trainees. Normally, I would have done a needle knife by now.
Yeah,
You're right.
so and I agree, and
Yeah.
but it's very important to show everybody, like that you are gonna get the case difficult cases,
Yes,
and and he's trying to show the technique and trying to show
अब
his
इधर वो
patients.
करें थोड़ा सा. थोड़ा सा अब थोड़ा सा एडवांस करें. एंगल ठीक नहीं है इसका. हाँ हाँ वो उसका वो हो रहा है. एक मिनट. इधर उधर इसको बो करें. हाँ यहाँ पे ठीक है. इधर ट्राई करें. एक मिनट. नो अब नो. ये इधर ऊपर है इसका. जस्ट अ सेकेंड. बो करें. एक मिनट. बाहर थोड़ा सा बाहर निकालें. अब नो. अच्छा ये bow.
Yes, sir.
Okay. बो करेंगे जा रहे हैं अंदर के नहीं नो ट्राई करें हाँ बैंक किया था वापस करें मेरे ख्याल में नीडल लाइफ कर ही देते हैं हाँ क्योंकि आई थिंक इट्स अबाउट टाइम बिफोर इट बिकम्स टू ठीक है हाँ नीडल लाइफ ठीक हाँ हाँ वो एक मिनट मैं उसको वो करता हूँ आप ये निकाल लें ठीक है जी
मैं निकाल रहा हूँ।
एक स्क्रीन मारें के ठीक है
को ब्लाउज
ठीक सॉरी Not very frequently, especially with wire technique, but quite rarely in fact. This is a yeah. Saad, hello.
Yes. Bakar, I know you're.
Yeah, I'm just looking at the direction of the cut that we are going to make.
Yeah, yeah.
Okay,
We,
so
we,
just,
I know you've been very patient, and I appreciate.
Yeah. So I'm just going to have a look at the direction that I should need.
Bakar, just there was a discussion. So while you're actually,
Okay,
you've got good pancreatic access here. Do you ever de-roof the ampulla using that access that you have, just so that you can get?
Yeah. That's what I'll use. Yeah. So
Okay.
we'll use the pancreatic wire as a guide, and I'm just looking at what would be the best direction of cut.
Okay.
Because the papilla is a bit, if you look at it, it's a bit twisted. So even the pancreatic duct is not in the expected position. So I just want to make sure that we make the correct cut. And obviously, right, okay. So you have to remove tension from the pancreatic wire. हाँ जी, अब oops, needle out.
haircut rather than a big cut. Below up. I don't know what this is a nice juicy papilla with generally I always do. The practice I have, I'm comfortable with it, so I
Oh, sorry. Huh?
unless I see a nice one,
I'll lगा देते हैं, I think pull off.
that's a different thing, and I'll cut anywhere I want to because you can see you know where the up जाओ या नीचे जाओ. Probably sometimes it's better to the
I think that is CBD. Right, so you can, I think you can see the CBD lumen there, orifice, yeah? Okay.
Yes, Waqar, we can see that.
Yeah, okay. So, okay, fine. So it was sensitive there. I think we've lost our pen. Yeah. ये जरा थोड़ा move कर दें. We might have lost our pancreatic wire.
and keep in mind that you all reuse excessively.
I think we've lost our pancreatic wire anyway. Not to worry. Yet are we?
You know, the tip is not as smooth as it is for the first time. So wire is, even otherwise is good, but in our system, wire is probably only very well.
Right, okay.
You can see the opening there, so you just beautifully put. Can you all see it? All appreciate it?
Yeah, the opening is right there, and then the finger around it.
You can see the muscle there. You can see the muscle.
Yeah, muscle around, and you see the bile coming around there.
Because he doesn't want to put a piece.
Hmm?
Yeah, I will do exactly what Khalid did.
Waqar, can you hear me?
Wire वो कर.
नहीं, Waqar सुन नहीं सकता.
हाँ, yes, yeah.
There comes the wire.
ये तो pancreatic है. Oops.
I think after needle knife washing is very important. Sometimes it's lucky you have no bleeding there. Sometimes you can have a little bit of
थोड़ा सा bow कर दें जरा.
I wash it. I use definitely flush or spray sometimes just to clean the
Bow.
if there is a little bit of bleeding, but not really.
जा रहा है. ठीक, okay. Right. कॉन्ट्रास्ट जरा इंजेक्ट कर दें, ठीक है? हाँ जी. ओके. राइट, ओके, ठीक. चलो. हाँ, वो काफ़ी है, ठीक है. अभी बाकी प्रॉपर सेंसॉटिंग कर देते हैं. राइट. Ready for cut. Yeah.
Well done, Waqar.
Thank you. I think that should be enough.
Waqar, I'm sorry, the fluoro from here, is there anything just distal end pe? Or is it stricture?
No. Right, okay. No, I think it's just a normal, there's no structuring. अदर वो दे दें ये balloon, ये exchange, ठीक है? Right, okay. Wire ठीक है? Screen कर लें जरा check position. चलो ठीक है, secure है. हाँ जी ठीक है, सही है. बाला कर रहे ठीक. Right, okay. Wire में break देना.
At this moment in time, you've done your job, you've got no big stone, you just need to do the little sleep to do what's happening, and that's it. This is good enough.
This is a normal CBD, sir.
This is normal CBD. I think there may be stone in somewhere, but it's not visible as such. We just do a balloon trawl. ठीक? हाँ? हाँ.
But if you can do a balloon sweep, around say you've got a 1.5 centimeter balloon that comes out. Carefully or not every week, no reason.
या बल्कि थर्मैन को दे देता हूँ. इसको दे देता हूँ. ठीक है? अभी तो हो गया काम.
And you put a balloon, you manage it to pull a...
हाँ, in fact, बच्चे राशि, you can do the balloon trawl. ठीक है? It's position put the lava, pass the balloon, right? Okay, right.
I think in our setup it's not...
Yeah.
It's not...
Keep going. Okay. Take a bit of time. Wire, make sure that okay. Keep looking at your wire. Make sure that he's maintaining tension without taking the wire out. Okay. Wire lock का बचे. जब तुम नीचे इंस्ट्रूमेंटेशन करो, अब देखो लूप बन गया ना. लूप नहीं होना चाहिए. You should be able to visualize the wire. ठीक है. अब इसको लॉक करके balloon को नीचे ले जाओ. जब वहाँ पे पहुँच फील कर लो, फिर release the balloon. फिर release the bridge.
If you start bleeding and you stop cutting, if you start bleeding, you don't have to stop cutting. Just because if you were cutting in and start
हाँ?
bleeding, then you
अच्छा okay ठीक है. Allow. Advance. Now visualize it where you are up to. ठीक है. ठीक है. Go up. go अब इधर स्टॉप कर लो. ठीक है. बस वहाँ पे ऊपर जाओगे फिर वो पेन होगा उसको. अब inflate and lock. And lock. Screen. थोड़ा सा ऊपर चले गए. हाँ ठीक. थोड़ा नीचे कर लो बेटा, उसको तकलीफ होगी. हाँ अब ठीक है. अब हाँ बैलून को पुल करो. पुल इट आउट. और ये देखो स्टोन डेब्री निकल रहा है. ठीक है. गुड. हाँ. कीप पुलिंग आउट एंड ट्राई टू पुल. अच्छा अब ज़रा वो स्क्रीन कर लो ज़रा वसीम प्लीज़. हाँ ठीक. हाँ वो मैन्यूवर भी कर सकते हो. ठीक है. इसको पकड़ के और बैलून को पकड़ के राइट वो करके और इंसर्ट द. हाँ ठीक है. तो इट विल. अच्छा स्क्रीन भी कर लें इस वक्त.
कैन यू जस्ट शो अस द फ्लोरो प्लीज. थैंक यू.
ठीक है. हाँ ठीक है. तो हाँ ठीक. पुल आउट हो गया कि नहीं. हाँ ठीक है. आउट हो गया. गुड. हाँ डिफ्लेट नाउ. ठीक है. तो दैट्स कंप्लीट कॉन्ट्रास्ट सारा निकला है बाहर. ठीक है.
दिस इज अ 1.5 सेंटीमीटर बलून.
हाँ ठीक है. डिफ्लेट करके निकाल लो. हाँ वो खैर है. वो तो मतलब निकल आया ना. हाँ हाँ दोबारा कोलेंजोग्राम कर लें. ऑक्लूजन कोलेंजोग्राम. इसको ऊपर ले जाओ बैलून को फिर वापस.
Was there a stone that came out? There's
I think there were a few small ones.
Okay, fine.
मतलब उसमें कोलेंजोग्राम पे विजिबल नहीं थे, लेकिन हाँ अब स्क्रीन कर लें बेटा. ऊपर ले जाओ और भी. ऊपर. कीप गोइंग राइट टू द टॉप. हाँ बस इधर ना. थोड़ा सा नीचे. हाँ थोड़ा ज़रा. हाँ इन्फ्लेट बैलून एंड लॉक. अब बेटा ये जो ही इन्फ्लेट वो करेंगे आप पुल आउट करो. ही इंजेक्ट कॉन्ट्रास्ट आराम से. ठीक है. ये अब ऑक्लूजन कोलेंजोग्राम उसको कहते हैं. इट जस्ट टू मेक श्योर कि कोई स्टोन बचा तो नहीं है. ठीक है, तो यू गेट अ गुड ऑक्लूजन कोलेंजोग्राम और पुल आउट करो, और करो 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 करो। खैर थोड़ा सा बैलून डिफ्लेट कर दें आसानी हो, एक बाय वन में। हाँ ठीक है, कीप कमिंग आउट बेटा, कीप कमिंग आउट। हाँ ठीक है, आउट 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 कम्प्लीटली, कम्प्लीटली आउट, पुल आउट, पुल इट आउट। हाँ और डिफ्लेट ही कर दो बस। हाँ ठीक है, दैट्स इट, वेल डन, गुड। चलो चलो जी। हाँ अब अच्छा, अब इसके जो लॉक्स वॉक्स हैं ना जितने, वो सारे अनलॉक कर दो, ठीक है। सक आउट द एयर फ्रॉम द स्टमक, स्टमक में थोड़ा रोक के एयर सक आउट करो खूब। हाँ ठीक है, आराम से सक आउट करो एयर। हाँ ठीक है। हाँ देखो जब चलो भी ना तो आराम से करो, एरिक ने पकड़ा हुआ इसलिए क्योंकि एयर आप निकले, अदरवाइज पेशेंट उनको काफ़ी तकलीफ होती है। ठीक, हाँ ठीक है जी, ओके जी।